Tokyolive,
Endoscopy 1.
Well, good day. My name is Greg Ginsberg. I'm a professor of medicine at the University of Pennsylvania in Philadelphia in the United States. And I'm really pleased to be invited by Haro to moderate this session in Tokyolive. This session is entitled Notes, the Current Status and New Horizons. And we have two phenomenal speakers who have been real pioneers and substantial contributors to the field. So I'm really pleased to first introduce Anthony Kalu, who's the current chair of medicine at Maimonides in Brooklyn, New York. This is after a really storied 30-plus year career at Johns Hopkins University Hospital, where he finished as the chief of the GI section there. He has been a mentor to so many. And of course, he has been a pioneer in notes. And so perhaps no one better to speak on this subject, evolution of surgery to endoscopy. So Tony, we thank you very much.
Thank you, Professor Ginsberg, for that very kind acknowledgement. I would also like to thank Professor Inoue for his invitation to speak at this very illustrious conference. As Dr. Ginsberg said, the evolution and changes of surgery to endoscopy has always been my passion. So I'm very pleased to be able to give you some of what I think lies in the future of endoscopy, and probably not so good future of surgery. As you know, that there's been quite the evolution of surgery to endoscopy over the last 4 decades. Conditions like colonic polyps, bile duct stones, and pancreatic pseudocysts that were predominantly managed surgically are now exclusively managed today by endoscopy. We don't do colectomies for polyps, we do colonoscopies and polypectomies. Bile duct exploration is rare for bile duct stones. It's the standard of care is ERCP and sphincterotomy. And pancreatic pseudocysts, the first line of therapy is not surgical cystogastrostomy, but endoscopic pseudocyst drainage. And then more recently, achalasia, which was entirely a surgical procedure, because of Professor Inoue's research and pioneering work, is now treated by POEM. I want to talk to you today about some specific areas in surgery that are conditions that are predominantly treated surgically that I believe will now convert to endoscopy, and maybe even these surgeries will disappear. The first one I want to talk about is the management of obesity. As you well know, non-surgical interventions for weight loss don't work. If you use diet and lifestyle modifications, the weight loss is mild to moderate, with the study showing a 5 to 10% weight loss. And weight gain is almost universal in all patients who lose weight by this method. Pharmacological therapy works with modest efficacy, but if you stop the drugs, the weight regain occurs. And pharmacotherapy is expensive with side effects. Surgery, by far, is the most effective therapy for weight loss. There's different types of surgical procedures that are shown here: laparoscopic gastric bypass, laparoscopic sleeve gastrectomy, and the band. And they work in 2 main mechanisms: by decreasing the ability to absorb food and decreasing the size of the stomach. But there are challenges with bariatric surgery. There's a morbidity of 3 to 20%. There's a mortality of 0.1 to 0.5%, but in some studies can be as high as 5%. 8% of patients need reoperation, 15% of patients become malnourished, and 25% will regain some weight. And then this is an interesting study that was done that looked at patients who were not interested in surgery and the reasons why. half of the patients said they were afraid of other complications from surgery. A lot of patients that felt like they did not need surgery to lose weight. They were afraid of dying or fear of surgery in general. Cost, pain, did not believe it would work, fear of judgment, and religious reasons were all reasons that were given. So we have here a sort of a unmet need for many patients who don't want to have surgery. An endoscopic approach to weight loss is attractive. It's minimally invasive, but relatively cheap. It can be an outpatient. Presumably, the ideal procedure would be repeatable and reversible. It could be multi-purpose, not just for, can be for cosmetic weight loss or to treat diabetes or a bridge to surgery. And as I said, in a certain group of patients who don't want to have surgery, it may fill a large unmet need. Now, over the last 20 years, there have been endoscopy. We've looked at many ways of targeting endoscopic therapy. In the stomach, space-occupying lesions such as the gastric balloons, gastric remodeling, outlet obstruction, aspiration of food, and altering motility by Botox have been used. And in the small bowel, sleeves, duodenal resurfacing, various types of anastomosis or flow-altering devices have been used. So we have a wide array of therapies, some of whom have had moderate success, but I believe that the technique that is probably the most viable is the one that actually mimics surgery, which is the endoscopic sleeve gastroplasty. And because it effectively reduces the size of the stomach, here you can see on the left-hand side a surgical sleeve gastrectomy, and then you can see the endoscopic sleeve gastroplasty resulting in a significant reduction in the size of the stomach as shown in the images below, which is before and after ESG. We did a systematic review of efficacy and safety of endoscopic sleeve gastroplasty. It was a systematic review and meta-analysis. We looked at 8 studies of close to 2,000 patients that have ESG. And what was interesting was that the total body weight loss at 6 months was significant, 15.1%, and the BMI dropped by 5.5%. But even up to 24 months, that this was a really sustained weight loss of 16.5%. These adverse effects were not common, and the serious adverse events were reported in 2.2% of patients with 0 mortality. So I believe that the endoscopic approach to weight loss using ESGE is real. The results show that there is a statistical reduction in the weight loss. This weight loss is sustained for 2 years and beyond, and it's reproducible among centers. What is the next step? I think the next step is actually continuing the simulation of ESG to what the surgeon does with laparoscopic root-wide bypass, and that is to add an endoscopic gastrojejunal bypass to ESG. So after you do your ESG, or maybe even before, I think after, you use EUS, and using the lumina posing stent, you can, perform a gastrojejunectomy, and this is a procedure that's being done routinely now for malignant gastric outlet obstruction. Truly, we will see significant weight loss with this technique, and there are already ongoing trials using this combined approach of ESG and gastrojejunal bypass. It is not difficult to think of a stepwise approach to weight loss using only endoscopy, where with patients who have maybe who want cosmetic weight loss of low BMIs, and who wants to go to a wedding or wants to get married, you can do a very minimally invasive technique such as Botox injection or place a balloon, and then you can get progressively more invasive endoscopically as the BMI increases. And then in the super obese, you may start with a balloon insertion, and Botox gastric injection to reduce the weight first, to improve the outcome, and then do an ESG with bypass. So we could see a stepwise endoscopic approaches to weight loss. The next area of the future, I believe, is in the management of gastroesophageal reflux disease. And gastroesophageal reflux disease, life modifications are effective. If you lose weight, you do a low-fat diet, you reduce alcohol and coffee, eliminate offending foods, you will improve, which are good, but patients tend to be non-compliant. However, medications are very effective, especially PPIs, proton pump inhibitors. The problem is that there have been concern with PPIs. Not only does it alter the GI bacteria, increasing the incidence of gastroenteritis and C. diff colitis, it may predispose to small intestinal bacterial overgrowth and pneumonia. Furthermore, there's decreased absorption of iron, calcium, magnesium, and vitamin B12, and alters the effectivity of a commonly used medication, Plavix. And bone fractures because of calcium absorptions are more common in patients with long-term PPIs. And then more recently, in the JAMA in 2016, a large cohort study looked at over 73,000 patients who were older than 75. This was a German study, it was a German health database. And what they found was that regular PPI users had a significant risk of dementia. And this association was interesting because patients with dementia have increased brain levels of beta amyloid. And if you feed PPIs to mice and you check the brain beta amyloid, it also goes up. So this could be more than just a causal association. There may be something more to this. And then the other study also published in the JAMA showed that patients who were on long-term PPI, and this was a US study in the Geisinger health system, showed that long-term PPI use was associated with chronic kidney disease with an adjusted hazard ratio of 1.35 for ever using a PPI and 1.46 for either BID daily use. I mean, once these two studies came out, there was a lot of public attention and patients were calling, I don't want to take PPIs anymore. What can we do? Well, there are several non-medical treatment options for GERD. There's a surgical Nissen fundoplication, and then there's a LINX procedure. And with regards to endoscopy, I will just talk a bit about Stretta and transoral incisionless fundoplication. And the surgical interventions have been, the laparoscopic Nissen fundoplication has been around for a long time. It works well. You perform it by doing a 360-degree wrap of the fundus around the esophagus. And the LINX procedure, which is a more recent addition to the surgical interventions, uses these titanium beams with magnetic cords that's placed surgically around the LES. And it acts as a bolster to increase augmenting the lower esophageal sphincter. With regards to endoscopic therapy, Stretta has been around now for a while, and you can see here, many of you are very familiar with it, I'm sure, where you place thermal energy using radiofrequency waves, and it's applied to the LES. And this results in reducing postprandial transient LES relaxation. It increases the compliance and stiffness of the gastroesophageal junction. But it probably really works by decreasing esophageal acid sensitivity, because when you look at studies that are carefully done, the amount of reflux that is really not significantly reduced by the Stretta procedure, but the patients feel better. So we're burning their nerves and they feel better. So it's not, for me, a procedure that I feel strongly about. On the other hand, again, in the same principle of bariatric surgery, we have an endoscopic procedure that mimics surgery. Transoral incisionless fundoplication is an endoscopic fundoplication procedure, similar in principle to the surgical Nissen fundoplication. It can be done as an outpatient procedure. And this is a short video for those of you who have not seen it. Essentially, you place this the device on the endoscope is inserted through. And what your intention to do is to grab the lower part of the esophagus from the gastric side and pull the elongated esophagus and create plications and a wrap. And it's really a nice 270-degree wrap that you can make with this procedure. And again, what is really attractive to me is that it's really mimicking the surgical principles of for a Nissen fundoplication. So if you look at the mechanism of action, if you compare TIF for laparoscopic surgery, if clearly you can do TIF in reduced with hiatal hernias less than 2 centimeters. It was felt that you could not do hiatal hernias greater than 2 centimeters, but there's some emerging data to say that's not true. Like laparoscopic fundoplication, TIF is able to elongate the intra-abdominal esophagus. It's a fundoplication like laparoscopic fundoplication, and approximating, tightening the fundus, recreating the dynamics of the angle of His, and restoring the distal high pressure zone is identical in the mechanism to laparoscopic fundoplication. So for me, this is a procedure here to stay. And so I truly believe that that we will start seeing less and less Nissens and more TIFs as time goes along. The real future for endoscopy, to me, is in the treatment of GI motility disorders. And part of the frustration of treating GI motility disorders is that we really lack understanding of the pathophysiology. We certainly lack good medical therapy, and surgical interventions like gastric pacemakers have poor results. I'll give you an example of this. The NIH funded this large multi-center placebo-controlled study for looking at nortriptyline and idiopathic gastroparesis. It was a negative study. There was no difference. They funded, hundreds of thousands of dollars to show that placebo and nortriptyline was no better. There was no improvement in nausea, fullness, satiety, or quality of life or bloating. So clinicians have been very frustrated with GI motility disorders, and in particular, gastroparesis. But I think that this technique of submucosal endoscopy, which was a technique originally developed for entry and exit for nodes, which was pioneered by the Mayo Group with Chris Stout, I think really lies in the future of, and we see already that that POEM, which is a procedure, as I mentioned before, that Professor Inoue pioneered, was a first step in that direction, where we are able to take the endoscope and dissect into the third space, or submucosal endoscopy, and dissect the muscles, the lower esophageal sphincter. And similarly, that's been done for G-POEM and Z-POEM. So you can dissect smooth muscle in this space, in this submucosal space or third space. You can also sample the muscular layers, and I think this is a field ripe for studying. We don't understand motility disorders, and being able to sample the smooth muscle in patients with motility problems may be very helpful. It can also facilitate submucosal dissection, safely performing EMR and ESD. And I also think a lost opportunity is, not a loss, but an opportunity that is certainly there, is the ability for us to tunnel to a sphincter and implant devices or drugs or stem cells, into the submucosa. And I'm not going to spend a lot of time on this, but this simply shows the tunneling in POEM, but more importantly, the fact that we're in this space and there is opportunity for us to do stuff in this third space or in this submucosal space is of great potential. So I think that using submucosal endoscopy, we can tunnel to target locations like the LES, pylorus, fundus, ileocecal valve, anorectal junction, and we could implant motility devices or stem cells to replenish nerves that have been degenerated as well. And I do think that this is a very exciting future for therapeutic endoscopists as the future goes. The other thing, last area that I want to talk about is the use of miniaturized tools. And this is an area when I was at Hopkins that we were looking at and still continue to do studies on. And these is a technology called microgripper technology. And this is a device, these are sub-millimeter small devices. And this gives you the size of it here compared to the biopsy forceps. As you can see in section C, that's the microgripper. And these microgrippers are capable of opening and closes. They're like little hands that can flex and open and open and close and grab things. And this is a video that shows one of the early videos with the microgripper technology, showing this microgripper entering a capillary and advance to this clot inside of the capillary tube. And you can see the microgripper pulling on the clot and removing it. And these microgrippers, the way they worked, and we published this several years ago in gastroenterology that about biological tissue sampling, because these microgrippers, if you release thousands of them in the colon, you can get really a statistical sampling of the colon in patients with suspected dysplasia for this video is playing. With suspected dysplasia, you can see this is an example of a microgripper closing in response to external stimuli like temperature, and you can see the different shapes at different temperatures. Now, temperature is only one way of closing and opening. You can have different stimuli like pH, etc. Here you can see we're doing a cholangio. This is a bile duct cannulation of a pig. We're inserting the microgrippers into the bile duct of the pig, and then we're going to, they're going to open and close, and then using a small magnet, we're going to retrieve the microgrippers from the bile duct, which has collected tissue sampling, and we're able to really get good tissue. Using PCR, we can do high quality analysis of the tissue. So I think these untethered microgrippers can be useful for tissue sampling. You could implant drugs into these microgrippers and have them deploy them into the colon, and you can deploy local therapy. And I also think that you could do organ removal, and if you have enough of them removing tissues at a rapid rate, it can be an adjunct to notes in the future. So I think in addition to the first slide, if we look at the future of how surgery is going to evolve to endoscopy, I think bariatric surgery will be replaced by endoscopic bariatric procedures, and we have a wide array of them. GERD or Nissen fundoplication will be replaced by TIF. I think there's not much surgery for motility disorders, but third space, those submucosal endoscopic interventions will be there. And I believe that organ removal using technologies like microgrippers is part of the future for nodes and for endoscopy. Again, I would like to thank Professor Inoue and Professor Ginsberg for the invitation to speak. Very happy to be here.
Thank you, Dr. Kalu. That was really quite a tour de force. I have to say, I was really shaken in my seat when I saw the microgrippers, and I hope we'll have a little time in the discussion period for you to tell us a little bit more about that. I felt like I was maybe in a science fiction movie. Well, our next speaker really does not require introduction, but Haru Inoue, of course, is the organizer of this Tokyolive program, and he's a giant in endoscopy. And of course, you know, he really has been such an amazing contributor to surgical endoscopy as we know it today. Is a real innovator in endoscopic mucosal resection and in third space endoscopy, particularly with POEM, but also with anti-reflux therapies. And so he's going to speak to us now on POEF. It's worth recognizing that Dr. Inoue trained as a surgeon and then gained his proficiency in endoscopic surgery. And he's professor and chair of the Digestive Diseases Center at the Showa University. He's been a good friend for a long time. And so thank you, Haru, for inviting me to participate in your program, and we look forward to your presentation.
So thank you very much, Greg, for your nice introduction to me. It's my great honor. So you are the chair of this great session. So I would like to share my slide. Okay. So today I'd like to talk about the notes, current situation and the future. Tony already talked. He's a father of notes procedure. I myself inspired a lot from him. This is my COI. So this is a memorable shot at the time of DDW 2016. So Tony and myself and Jay Pashuricher and Mimi Kanto. So we are all together at the hotel lobby. So I hope soon we can meet like this again. So I'd like to talk about the treatment of chalazion a little bit. So submucosal tunnel myotomy was the first concept was first reported by Jay Pashuricher, Johns Hopkins. So honestly speaking, in the lobby of our hospital, I read this article. When I watched this article, I think we can do it in human. That's a true story. Then, so 2008, so our first case, so we did clinical POEM procedure, power endoscopic myotomy. After that, so far in our hospital, more than 2,000 patients received, 2,300 patients received the POEM procedure. Our effective ratio is so 92 to 100%. So these are in most of the high volume center. So this clinical results is so good, I think. But the potential problem of the POEM is the post-POEM GERD, 20 to 50%. So how to avoid the post-POEM GERD? It's a simple way. We recommend the double scope method to control the gastric myotomy length to 2 centimeters. So double scope method is originally reported by the Portuguese doctor. This is a technique. So we using the intragastric second scope, we control the gastric myotomy length approximately 1 to 2 centimeters, like this way. So this is a best objective evaluation of the gastric myotomy length. Dr. Kevin Grimes, so he reported RCT and his conclusion using 100 cases. So his result was the gastric myotomy length more than 3 centimeters. That increase the risk of more than moderate esophagitis. So that is a simple method to control it. So next, I would like to talk about the POEM plus fundoplication. So it's a kind of a pure notes procedure. Yes. So yes, I will talk step by step. The first case was done in the 2017, 4 years ago. And so far, we performed 45 cases so far. So this is a live demonstration at the time of the ESG days, 2 years ago, not in a plaque. So we have already published. So now we are using the, first we use the clip under snare technique, but now we switch to our suturing technique. So we use the endoscopic suturing devices from Olympus. Dr. Goto developed this device. So actual procedure is like this. So creating the submucosal tunnel in the anterior wall of the esophagus, the distal end is reached to the stomach, gastric caldera, the submucosal layer. And then, so we are getting abdominal cavity as a distal end of the submucosal tunnel. And then, so in a lateral flex position, we try to suture the anterior wall of the stomach in a full layer fashion. So distal end of the brelock, there is some felt that fix the wrap. And that, we also place the proximal anchor and then pull the brelock. Then we can make a tight implantation. So this is the case. So in the anterior wall, in the submucosal tunnel, muscle layer already dissected. Now we are dissecting the peritoneum. Behind, you can see the back side of the left liver lobe. Now we open up the peritoneal cavity more and more using TTJ. Then get in abdominal cavity, insufflate the cavity with a CO2 gas, and then so keep a lateral flex position. Now we rotate the needle holder. We are trying to catch the anterior wall of the stomach. So this is an intragastric endoscopic view, this monitoring. So needle is coming in the gastric lumen, it catches the mucosa, so full layer, that means. So needle is going out. So please note also, this is a case right after Cohen procedure, junction is open, so potential risk of GERD. So this is a proximal anchor in the distal end of a submucosal tunnel. Now we are catching the light course, diaphragmatic course. As a place suture on it, the big bite. Yes. Then we pull the brelock. We can make a fundoplication like this. This is an anterior partial fundoplication. This endoscopy image is very similar to our after door fundoplication. And also, well, this looks very similar to Belsey fundoplication. Very mild fundoplication. So one more case I like to demonstrate. So 50-year-old male Japanese patient. The patient originally has a distal esophageal spasm. That is a primary disease. And after POEM, so patient becomes a refractory GERD. Then we perform this procedure. Anyway, this is a case before POEM. So you can see a high resolution manometry. This is a typical findings of spasm, and the endoscopic view are so distal part of the esophagus. There is some very tight abnormal contractions. So junction itself open, but in the lateral flex view, we can see a very tight contraction of the distal esophagus. Anyway, this case, we perform the POEM. And then, so this is a volume swallow before and after. So after, volumes are going very smoothly. So it looks good. And then our symptom score improved to 42. So looks good, but patient becomes a severe reflux. So 2 months after procedure, 4 months or 6 months after procedure. So patient has a grade C grade B, C, GERD, like this, some observation. So the 24-hour pH impedance study demonstrates some abnormal data. Then we decided to perform the pure nodes partial fundoplication. That is a 4-hour endoscopic fundoplication. Poem was done in the posterior wall. Then, yes, so 9 months after original poem procedure, we did this procedure in anterior wall of the esophagus. Okay. This is an endoscopic view. Submucosal tunnel is anterior wall. In this area, muscle layer is already dissected. And then now we are approaching the peritoneum. So catch the peritoneum and then cutting current, we open the peritoneum. And then using a TT, we open up the peritoneum defect. So after that, we get in abdominal cavity. Top of the image is abdominal wall, backside, and the bottom is a surface of the stomach. So lateral flex on the left turn, left rotation. And then, so using second scope in the stomach, insufflates the gastric lumen that keeps attention to the surface of the stomach. Now I'm trying to suture onto the anterior wall of the stomach, like this way. So after this, we place 3 stitches on the proximal distal esophagus crus. Then we pull the V-lock. Then we can make a like this fundoplication of the gastric caldera. So this is a very mild fundoplication. The lap will just cover the open hiatus. So very mild fundoplication. It's a similar to DOL concept. Because achalasia patient has no clearance of the esophagus, no peristalsis. So this kind of a mild lapping is very effective. So this patient, so after POEF procedure, this is a before POEF procedure. So it's 2 months after, PPI already off. And the 2 years later of this procedure, PPI off. And then so no erosion. And the symptom score, yes, I want to come back, but anyway, so symptom score is improved well. This is a GERD HLQL questionnaire. The patient checked, I'm very satisfied. It's written in Japanese. This is true. So far we performed this procedure, 45 cases. So far the result is so good. So technical completion rate is 100%. This is a pH monitoring. So comparing the POEM alone group and the POEM plus fundoplication group. The pH impedance study demonstrate the recovery. This is a power of a fundoplication. So everybody knows the instant fundoplication is the most strong one. And the toupee is a so-so. And the DOL is the anterior partial, originally developed to apply the like achalasia patients. So less clearance of the subfield body. So POEF, power endoscopic fundoplication, is similar to DOL. So like that. So arms and armor is another mechanism, so not equal. So this is our treatment strategy for esophageal achalasia. Achalasia and the related motility disorders, we routinely perform the POEM alone. So because So when we perform a double scope and control the gastric myotomy length less than 2 centimeters, so less risk becoming the severe reflux disease. So of course, 50% of the patient have the abnormal pH, and 20% of the poem patient had the symptom of GERD, but mostly controlled by the PPI. Then, so severe GERD, what I mean, grade C or D, and not respond to a PPI is 0.3% of the poem patient series. So in such a case, we approach anterior wall, perform fundoplication. So, as Tony mentioned, in the past, the open surgery, most of the treatment. And then that moved, 20 years ago, that moved to laparoscopic surgery. Now it's moved on to the flexible endoscopic surgery, nodes procedure. Okay. So thank you very much for your kind attention.
Thank you, Haru. That was really quite the tour de force. And as uncomfortable as I felt looking at Tony's untethered microgrippers, I felt even more uncomfortable watching you cut through the peritoneum and start swinging that needle around right next to the liver. You know, I appreciate what you said at the very end, because having learned how to do poem from you, it's a magnificent operation, and yes, maybe 20 to 30% of patients will have some reflux, but the vast majority of them can be really effectively managed with acid suppression therapy alone, and it's interesting and intriguing to see how we may add on additional endoscopic therapies to modify that reflux. But you know, what you were demonstrating, I think, is, you know, that is an approach that absolutely can mimic surgical fundoplications. What do you think it's going to take to bring that to a mainstream endoscopic intervention?
To me, so Greg, thank you very much. It's a very important question. POEF is, I think, a poem itself is approach in the submucosal layer and cut the muscle. So it's not a transluminal. So similar to nodes, but do not approach to other organ. So a poem is the nodes or not, I'm not sure. But so fundoplication, POEF is, I think, really a pure nodes, one of the application of the pure nodes concept. Yeah. So actually getting an abdominal cavity and catch the other organ, and it's place a suture in between a gastric wall and the distal esophagus. So this is, yes, you said, is a very quite mimicking to our dough fundoplication. So I think this kind of nodes, now I feel nodes again, or second generation of nodes procedure. So Tony, yes, he had the concept of the nodes, and already 15 years passed, I think. So now it's time again we think about the nodes.
You know, you could really, I certainly can envision designing tools that would facilitate that technique in a way that would make it safe, facile, reproducible, and in the hands of the many. Tony, what do you think? This is something you think and dream about all the time. So what are the things that you think that would be required to bring POEF to the mainstream?
So, first of all, Haru, congratulations again, another pioneering step. And it makes such good sense, it's logical, and I know this is going to make a huge impact when it catches on. I like to think about, when I look at endoscopy over the last few decades, I like to think about that we have different generations of endoscopists. When I finished my endoscopic advanced training over 30 years ago, I was told, I was doing ERCPs, and I was told, do not interfere into the pancreatic duct. You will be crazy to do pancreatic interventions. You get pancreatitis from ERCP. Why would you do that? And after my generation, there were people that pancreatic interventions were normal. You didn't think of it otherwise. That was all you knew, because that's at the beginning, when you did your training, everyone was doing that. Now we have a generation of therapeutic endoscopists that are coming out, which is seeing POEM as normal, and seeing, gastric bypass, doing endoscopic gastrojejunectomy as normal. And these are the generations that will actually take the next step, just like we did. The future for therapeutic endoscopy. Already, I have therapeutic endoscopists wanting to do this, POEF, and they're young, and it's because everything else is normal. What we think is very interventional, it's for them background. It's like what is already there, and they want to do something else. I think the nature of therapeutic endoscopists is actually, a real young therapeutic endoscopist is to do the next boundary. So for me, I think what we'll do is, like in anything else, we'll start getting greater patient experience, publishing the preliminary pilot studies, and then doing clinical trials. But I mean, it's a simple procedure. There is a barrier though, because even though we have ventured into POEM, and maybe we do PEGs and we cross somewhat into the peritoneal space. This is actually intentionally going into the peritoneal space. I wonder, Haru, has any cases been done in the US? Do you know?
So you mean
of POEF with the
POEF. Sorry.
Yeah, have any cases been done in the United States?
I'm not sure. So you must know it.
I don't think so.
Not that I'm aware.
I don't think so. Yeah. So now we're really crossing that boundary, and that's a big step. But I believe that I think the young therapeutic endoscopists, I think this is going to be where they're going to go after next.
But you can certainly envision that rather than trying to take a needle driver in the peritoneal cavity, that it would be readily that one could design a cinching mechanism with a suture that could make it much more proficient. And from my standpoint, a little bit of technology design could make this the next big thing and make it
I agree.
feasible.
I agree.
Totally agree.
I agree.
All right. Well, I on behalf of the course directors, as the moderator of this session, I'll bring this to a close. And I want to thank Professors Kalu and Professor Inoue for their outstanding leadership during their careers and for their presentations tonight. So thank you.
Thank you very much.
Thank you. Thank you. Thank you.